Hello, and thank you for coming to this presentation on EHR Disaster Preparedness, Lessons Learned from Hurricane Katrina. I'm Beverly Chester. The entire Gulf Coast of the United States was directly impacted by the path of Hurricane Katrina. States like Louisiana, Mississippi, and Alabama were hit directly, and levees failed, causing major flooding across the states. Thousands of people were displaced or evacuated, often to neighboring states. So the indirect impact of Hurricane Katrina could even be established in a wider area, including places like Texas. The United States National Hurricane Center stated, Katrina will likely be recorded as the worst natural disaster in the history of the United States, which just illustrates that the impact, direct and indirect, of Hurricane Katrina cannot be downplayed. The impact of the storm on healthcare was that an estimated 400,000 paper medical records were completely destroyed by flooding, meaning the paper was turned to pulp. Young children were separated from caretakers as they were evacuated to safe grounds or community-based relief centers. And some of them were so young they couldn't speak, meaning when they needed health care or food, it was often a guessing game as to how to proceed in those situations. Subsequent medical visits were virtually impossible to coordinate for the 400,000 people who lost their medical records, as well as to the additional people who had no direct access to their medical records, even if they weren't destroyed in the storm. So without a complete patient medical history or health insurance information, adequate care can't be provided. Pre-existing prescriptions were unable to be filled without the medical records and without the prescription history of the patient. And physical and mental health issues lasted for years afterward in these populations. This is especially important because the Gulf Coast, including Louisiana and Mississippi, is historically the least healthy and most vulnerable area in the United States. Learning from Hurricane Katrina, I've developed a preparedness plan. Hurricane Katrina was not a standalone experience in the failures of the United States healthcare system to prepare for natural disaster. The National Oceanic and Atmospheric Administration, or NOAA, predicts changes in weather patterns that will overall reduce the number of mild weather days. For example, we've seen countless severe weather storms, tornadoes and hurricanes and wildfires. We have also seen freezing cold temperatures in places like Atlanta, Georgia, and Central Texas that are usually hotter climates. So whether the natural disaster comes in the form of hurricane, wildfire, tornado, flood, earthquake, extreme heat, or extreme cold, the healthcare system must be prepared. The preparedness plan begins with just that, being prepared. We know that failing to plan is planning to fail. So here are the plans for before a natural disaster even strikes. We have to establish trust in leadership and establish appointed safety officers, at least one per clinic. And if the hospital is larger or if the clinic is larger, we should have safety officers by department. We should test evacuation communications, routes, and procedures. So starting within the clinic, the NICU response might be different than the emergency department response. And so we should test those systems accordingly. But then even greater than just the hospital or the clinic, we should test as a community. Local and state governments should have a preparedness plan that involves the clinic and the hospitals. We should also partner with private entities and community partnerships to make evacuation and communication more seamless. Further, we should develop contingency plans so that if plan A does not occur as desired, we could then go to plan B or C. There should be community-based disaster relief areas, and these areas should have on-site emergency medical supplies before a disaster strikes. We should map the most vulnerable areas or populations to know where to place these community-based disaster relief areas so that the most vulnerable populations are cared for. And finally, we should prepare for different natural disaster circumstances, such as how would the evacuation for extreme cold occur versus hurricane disaster relief, or even something more immediate and less foreseeable than a cold front or than a hurricane establishing, something like an earthquake. What would we do in that situation? We should establish vulnerable patient tiers and patient evacuation procedures for sequence of care procedures and protocols, meaning if there are patients that are less vulnerable and can be evacuated with the general population, we should do that. And we should have tiers of how vulnerable is a patient, what is their critically ill status, and should they evacuate by land routes or medevac, etc. We should coordinate standby and volunteer medical providers from out of state or out of area that could come in when a disaster strikes. And we should have the list of these medical providers at as many sites as we possibly could, especially community relief centers. We should establish secondary and tertiary servers for electronic health record storage. If Hurricane Katrina taught us nothing, it's the importance of having accessible health records. And so the EHR serves that purpose, but even an EHR can go down in an emergency if the electrical grid or if internet communications goes down. So having secondary and tertiary servers might help circumvent that issue. However, we should also have contingency plans for using paper records in lieu of internet-based or electronic records. We should establish secondary communication pathways to emergency response teams. So for example, police or firefighters often use broadband communication pathways, long distance walkie-talkie radios. And so we could have some kind of system that speaks directly with their systems should we need it. We should also establish alternative electrical systems such as generators. And finally, establish temporary emergency morgue locations. For example, with the COVID-19 pandemic and the extremely high death rate that ensued in places like New York City, there was nowhere to put the dead bodies as people passed away from the disease. So that could, one, endanger your living population, but two, it causes mental health issues and long-term depression and despair issues with the people who are working within the morgue locations. The response part of the plan is when the natural disaster strikes and how should the events unfold, what are the plans and contingency plans. We should report the natural disaster immediately to the safety officers. The source of where the natural disaster information came from, was it a media outlet, some kind of weather forecast, or was it something that was seen What is the current status of the disaster? What are the expectations or foreseeable circumstances? And what's the plan of action? Report the foreseen ability to evacuate patients and conduct the sequence of care protocols for vulnerable tiers of patients. Take inventory of and report needed medical supplies, equipment, and food. Connect to alternative electrical supplies and communication lines as soon as possible. Don't wait until you need the communication lines to connect to them. Adhere to practiced emergency response procedures whenever possible, with an emphasis on putting safety first. So if the practiced response is not the safest response, then redirect and go with a divergence, but communicate any divergence from the practiced response to the safety officer immediately. Follow real-time updates on weather status, evacuation status, and infrastructure status. That would allow us to redirect staff, equipment, and supplies as the natural disaster and its aftermath develop. Protect the most vulnerable whenever possible, again with an emphasis on putting safety first. The recovery stage of the disaster preparedness plan is for after the immediate impact of the natural disaster has waned, and now we're trying to regroup. So first we would establish or reestablish community-based relief centers, especially to reconnect family members, as many young children were disconnected from families during Hurricane Katrina and other storms. We should document emergency protocols that were followed and divergences made thereof. Conduct an equipment and supplies inventory. Conduct a personnel impact assessment that would allow us to provide personnel debriefing and mental health assessments where needed. And we should evaluate the adherence to protocols, any divergences, and contingency plans of the practiced protocols, so that then we could revise and edit the plans. Thank you for attending this presentation.